to all again. And though I had thought that Kolkata will be warm and humid, it was not so. I took a walk yesterday at 12 noon after coming here, and I was not sweating. So very welcome break for me after, the humid and hot environment that I have in Mumbai. Let me begin by, telling you that how and why did, we thought of summits like these. Because most of the time, we have conferences or workshops which are around management issues, operational issues, quality, human resource, or equipment for that matter, but very few conferences which focus around hospital infrastructure, something which we as promoters, as doctors even, as every doctor wants to have his or her own hospital, but your own in-depth knowledge about the building, that houses the beds and operation theaters is sketchy, and you start from a nursing home and you try to migrate to a bigger, hospital platform with the, experience of running a small nursing home. But when you migrate, that transition is very big actually. And many promoters have that, problem of coming to terms with the change. So you think something, and then when you build it, and they say, wow, this is so big and it's so complex. Okay, so talk of air conditioning systems, you talk of electrical systems, you talk of interior finishes. Mind you, you have to manage it, for the next 40 years, all right? So if you don't do that right the first time, you would be in deep trouble. The knowledge that you carry about maybe the human anatomy and physiology, similar amount of depth of knowledge is required to understand the anatomy, physiology of a hospital building, okay, because that also breathes, okay, you have air, changes, you have air quality norms, which are becoming stricter by the day. You have NABH standards, you have different standards, say for in West Bengal, you may have some different standards in some other state. But fortunately, this government has looked upon probably one of the biggest social sector reform in terms of Ayushman Bharat, which will probably bind all these standards and make one national standard. Okay, I can foresee that. I will talk about it during the last, session. So I think, this whole conference theme is structured, towards that and learn from experiences of each other, So we had started this about 4 years ago. This is, I think, the 5th year. There would be a 3-day exhibition cum conference in Mumbai, which would be on October 14th, 15th, and 16th, if I'm correct with the dates, where you have, opportunity to exhibit if you are from a vendor perspective, or from an owner perspective, you have the opportunity to come and meet and see many of these building-related infrastructure technologies and some new and emerging technologies which might change the way healthcare is delivered. We also, last year had a competition for green and sustainable hospital, wherein I was quite surprised that there were about 15 entries from large format hospitals. Okay, which were like 300 upwards, and Narayan Rudala had, I think, 4 entries, Apollo had 2, so there were a lot of bigger hospitals which had shown interest in something like that. We also conduct, an architectural competition for students. The idea is to, inculcate in the mind at a very young age that this sector, which has been neglected, in terms of infrastructure planning, probably some of them would, like to get into that, because hospital buildings probably one of the most complex, buildings that I can say. It's probably easier to build a mall. It's probably easier to build, hotels like these, because everything is standard. Air is almost same everywhere, same temperature, same air changes, not too much of, other problems of electrical, or you don't need an RO water, you don't need, an RF cage for an MRI. It is very simplistic, but hospitals need precision engineering, okay? So a neonatal intensive care unit will have a very different, engineering requirement than an operation theater which is doing knee replacement surgery than what is doing an eye surgery will be very different. Okay, microbiology might need something very unique to itself. Linear accelerator needs almost like a 6 feet thick bunker. So all these things make hospital buildings very different. So that's the attempt that we are making through these conferences. We have done a similar show in Hyderabad. We are doing this in Kolkata. We'll follow it up with one in Kochi, one in Ahmedabad, and then the final one in Mumbai. And I would invite all of you to visit to us in Mumbai. Coming to today's agenda of the day. So if you would have seen this booklet, it's more structured towards how technology is going to change. You will see quite a few number of items there are around that. Be it information technology, be it medical technology going to make changes, and many of them you would find will disrupt the way you conduct your business. Okay. There are also panel discussions around that where we will try to elicit from people who have been into this business for a long time, managing projects, managing procurement, managing equipment procurement, will be here, and you could probably ask your questions to them also. And it will be rounded off in the end by a IDEX big debate, where we have probably 3 or 4 stalwart personalities of Eastern healthcare, where we will try and pick their brains as to how do they foresee Indian healthcare, which is going to probably, I can say that Ayushman Bharat, is one single thing which is going to disrupt, the way you are going to run your healthcare business in future. Because never before, you had 1/3 of the country's population getting driven into hospitals with a 5 lakh cover, which is, I had a 5 lakh cover actually, not very long back. Okay, so that's tremendous amount of money power that we are getting into patients' hands. And this will now depend on you as to how do you respond, to that kind of a challenge. So that debate, please don't miss it. It would be very interesting to hear to that debate. On this note, let's begin today's proceedings. We have with us, very young, dynamic personality with us, Dr. Rohit Rao. He heads the clinical and business development Stasis labs out of Bangalore. And you just read his CV and, it is quite inspiring. He completed his medical training, St. John's Medical College, Bangalore. He was the HSBC Scholar-elect and pursued a master's in immunology from University of Oxford and the Crux Scholar-elect 2007 to pursue his PhD in oncology from University of Cambridge, UK. Subsequently, he worked with global pharmaceutical companies in UK and Europe to build compelling brands through product positioning, branding, communications with Sadler and Hennessy. He was also with London and TVF Communications as a key account manager, and finally decided to relocate, and that was good for India, to work as a healthcare consultant with Ernst & Young in the healthcare advisory team. So you can see what MBBS doctors are also capable of doing. He's worked with Indian hospitals on performance improvement, projects to achieve cost transformation, EBITDA transformations, pricing, procurement, and I think then something snapped in his brain. And he now leads business development, sales and marketing team at a company called Stasis India, about which he's going to talk. I have seen his presentation and I'm quite impressed with the product. So without wasting much time, I'll call Rohit Rao on stage to share his product.
Thank you, Dr. Desai, for a very elaborate introduction. I'm humbled to be here. Thank you very much to IDEX for the invitation as well. Can I have the deck, please? So I'm not going to talk too much about the product per se, but really try and set the stage for the panel discussion that's going to follow. and we're going to be talking about the transforming patient experience and clinical outcomes with technology. The topic of my conversation today with you is going to be on building hospitals with smart technologies to improve patient safety and improve clinical outcomes, and also present a retrospective case study which hopefully will shine light on how you can implement technologies usefully to actually transform patient care. Excellent. So, as all of you know, and I think this is more relevant in Calcutta than anywhere else in India today, the healthcare landscape is changing a lot. You have revenue pressures from drug price controls, price capping, change in payer profiles. At the same time, you have cost implications of rising manpower costs, accreditation requirements, changes in the way people do business in India, as well as the incidental costs. Now, what hospitals really need today is to really rethink their business models. I know being part of a consulting team at EY, one of the key projects that we were doing was cost optimization. Now, I stress on the word optimization because the knee-jerk reaction when someone says change business models is to cut costs. Really what hospitals need is cost optimization, and there are several methods of doing that. Technology is not the only solution, but it is one of the key solutions that can actually help you in that space. But today, I think hospitals are being bombarded by a lot of technology innovations that are coming into various areas of the hospital. As providers yourself, you will agree that one of the issues that you have to deal with is how do you assess these technologies? Now, there's a very interesting concept called the Gartner hype cycle. So this essentially helps providers really assess where in the cycle of innovation is the specific technology that you're assessing. So typically, you have your peak of inflated expectations when there's a lot of media hype, new technologies being introduced, there's a lot of promise that they're going to change the way things work, which then eventually leads to the trough of disillusionment when things don't necessarily pan out. And I think one key example is Google Glass. Everyone is really excited about how it would change our social interactions in healthcare and manufacturing, several sectors. But really now I think, we rarely hear about Google Glass anymore, except for very specific use cases where it's now segued into the plateau of productivity. Now, where in this scale as a provider do you stand? Typically, you have your early adopters, who are people who adopt the technologies when there's the hype, when there's limited data available on the actual usefulness of the solution. And as the product or the innovation matures, you have the mainstream adopters who will then take it up for specific defined use cases which have been defined by the early adopters themselves. Now, the issue with that essentially is that at that time, you lose the risk, the benefits of early adoption, and you're actually paying premiums for something that you could have obtained at a much, much cheaper cost. So should you then be integrating technologies? That is the question. Now, if there's one message that I want to leave you guys with today is to really introspect and think about where on this cycle would you like to be. Now, as early movers take an informed risk, they pick up technologies that are in their early stages with limited data available, but are willing to invest for a clear indication and will reap the benefits thereof. Think Bitcoin, right? Like everyone who bought Bitcoin 10 years ago is now essentially a millionaire, if not a billionaire. Your moderates and more cautious adopters and do a lot of due diligence, wait for some of the early data to trickle in, and often rely on a cost-benefit analysis to really think about tech adoption. I think the Indian space is predominantly governed by the moderates, if not by the late bloomers as well. Now, the late bloomers are the ones who will adopt technology once it's mainstream. The downside to this is that the maturity of the product has already happened and you're going to be paying premiums, nor are you able to govern the initial use cases where the product was initially launched for. So I would urge all of you guys to think, introspect, really understand what are the key issues that you have and how do you solve these challenges with technology by being early movers or even moderates. Now, don't necessarily ask for tons of data. You don't need a lot of validation to happen. You need some validation, I agree. And I think if you're clever in the way you implement a specific innovative, disruptive technology, you will be able to, in a controlled environment, understand what the specific use cases are, what the implications to you as a provider are, and then scale across if it works. If it doesn't, drop it. It's the cost of the risk that you would have to take, and it's an investment at the end of the day. So I want to take you through a quick case study of how we were able to improve clinical outcomes with remote patient monitoring and improve patient safety, and above all else, improve affordability as well. So the challenges faced by our client was very similar to challenges that you face today. Revenue concerns due to loss of revenue from unavailability of ICU beds, increased lengths of stay in the hospital, impacting top line, lack of CapEx budgets to actually bring in new technology. So they really needed to look very carefully at the cost benefit to ensure that they were able to actually bring in useful technologies. They had a high input cost because of nursing turnovers. And when I was doing studies with EY, across the board, nursing attrition was almost 20 to 30%. Now, there is a lot of HR cost that is involved when you have such a rapid turnover of nursing. The other aspect was on patient safety and clinical outcomes, where they had code blue rates of 1 in every 600 patients in the specific ward that we were looking at, as well coupled with low-skilled staff, which really doesn't help the patients in any way. So we implemented Stasis continuous care system to improve patient care, improve patient safety, and improve clinical outcomes. The system essentially consists of 3 parts. You have the bedside monitor, which we have essentially rethought the design of. There are no waveforms and numbers by the patient's bedside anymore. It's represented by pre-interpreted color-based icons. All of the data that's collected, this essentially automates data collection and documentation, freeing up 15 to 20% of the nurse's time that she's today collecting data on and documenting this. 6 key vitals being measured: heart rate, oxygen saturation, ECG, respiratory rate, blood pressure, and skin temperature. All of this data is collected, and it's centralized with the Stasis tablet, which does automatic early warning scoring. It also ensures that all of the data that's on the tablet is then pushed to the Stasis cloud, where clinicians can remotely access the Stasis app and check up on their patients from anywhere in the world. The benefits essentially were this new disruptive payment model where we introduced. It's entirely an OpEx model, no CapEx costs involved. It's almost a running cost, monitoring provided as a service on an annual subscription basis. There was zero infrastructure required because we ensured that the system was built to scale across private and public sector hospitals. And for all this, they got an FDA-grade system. Now what they created essentially was a low-cost, high-acuity ward outside of the ICU called the acute medicine ward, a 10-bedded ward managed by just 2 nurses. Typical HDUs have a ratio of 1:3. These guys were functioning at a 1:5 ratio. So you have your reduced input costs on manpower. All of the data was then available remotely for the clinicians to manage, so there was no requirement of a clinician being present at this external site, at the acute medicine ward. They could be remote, and they could still manage the patients effectively. So again, you're optimizing your cost there. Quickly running through the actual metrics. Now, they monitored 470 patients in a 5-month window from September to Jan 2018. So this is the control period pre-Stasis, where patients were directly pushed into the ICU if they were vulnerable or if there was an index of suspicion that this patient was going to deteriorate. Post-Stasis implementation, all of these patients were funneled into the acute medicine ward, managed there for anywhere from 24 hours to days, and only with a clear indication were they then escalated to the ICU or pushed into the ward or discharged. These are excerpts from our KOL talks at other conferences, and I just want to present some data very quickly. We saw an 88% reduction in ICU load with our acute medicine ward implementation. Now, after 48 hours of being admitted into the acute medicine ward and being continuously monitored, only 11.2% of patients required ICU level escalation. Meanwhile, the rest 88% either stayed in the ward for continuous monitoring or were shifted to the low acuity wards. Now, the benefit for providers such as yourself is really based on what your ROI on that system is. And our clients were able to really recover their ROI within the first 6 months. And how did they do that? Their ICU occupancies remained unchanged, so we solved their initial problem of having revenue leakage. The average revenue of the ICU, average revenue per occupied bed of the ICU also went up almost by 13% because more deserving cases were being treated in the ICU. The average bed revenues across the hospital were also increased because now you have a low-cost, high-acuity bed that's sitting outside of the ICU that's essentially managing all of these vulnerable patients. And there was significant cost savings from the nursing and the clinician manpower being optimized. One of the key issues of tech implementation, and you will hear this from our panelists, is end-user adoption. And Stasis, as a system, had phenomenal end-user adoption. Clinicians, we interviewed 21 clinicians, and 90% of them were satisfied with Stasis. 95% of them saw the utility of the system during off-duty hours, and the confidence in admitting patients in this high-acuity ward outside of the ICU was also very high. So this meant compliance and also meant we were able to churn through a lot of patients in the acute medicine ward. From an operational perspective, you can see I've done a quick comparison of the pre-implementation period and the post-implementation period. ICU occupancy, as I said, remained unchanged. The average revenue per occupied bed actually was 1.2 times in the post-Stasis implementation period. A number of patients managed was actually 30% more, and your ICU A-loss actually reduced by 23% with Stasis. So we added a new source of revenue to the hospital, which was actually generating almost 66% of an ICU bed outside of the ICU. I think one of the slides that I accidentally skipped across was the clinical impact, which was eliminating code blues in the hospital. Prior to Stasis, they had 1 in 600 patients who were throwing code blues. Post-Stasis implementation, and this was on a number of about 1,700 patients being managed in the control period. Post-Stasis implementation, they were able to effectively manage 30% more patients, which was about 2,200 patients during that 5-month period that I mentioned, and they had 0 code blues. None of the wards that served as catchment areas for this system had a code blue in that time, and we're yet, fingers crossed, we're yet to see a code blue in our specific area of implementation. With all of this evidence now, our client has actually planned to scale up across the hospital to ensure that we're hitting the key areas where they have similar issues, having tested it out in a very controlled manner. And this is something that I would encourage a lot of the providers here to do. You don't necessarily need to scale on day one. Understand your use case, implement a solution, figure out what the best solution is for your hospital, and only then should you be thinking about scaling up a solution across the hospital. So, in effect, today's hospitals predominantly, if you look at the revenue cost, if you map it against revenue versus cost, your ICU beds are typically high cost, high revenue beds that sit in the second quadrant. Your ward beds are typically your low cost, low revenue beds that sit in the fourth quadrant. We essentially help our clients move into the first quadrant, which is your high margin quadrant. Essentially low cost, but high revenue. And this is essentially where the future of hospitals lies. And this is where technology can really assist providers, given you are running controlled experiments before you invest too much in scale in a specific technology. Really understand the use case for you, understand how the solution fits in, ensure that there's user adoption, and I'm sure you will be able to realize the clinical and the operational benefits of a system like ours. So our client was essentially able to leverage the technology in a very traditional market by implementing what we refer to as low-cost, high-acuity beds outside of the ICU. Love to take any questions if you have any before we segue into the panel. Dr. Desai, how much does it cost? So as I mentioned, we are a fully OpEx model. We charge for monitoring as a service. So on a per bed basis, it costs the patient anywhere from 150 to 300 rupees per bed per day. It's as cheap as that.
When you use it, or it's, you have to pay flat?
It's flat because you can technically have more than one patient on a given day, depending on how the clinician wants to use it. Cloud9, for example, uses our solution as a surgical ICU, in their surgical ICUs or post-op, where patients are only there for 2 to 4 hours post-surgery, just being managed to ensure that they're safe before they go back into their private rooms. And they're churning through 10, 20 patients every day.
And with that, the monitor, the tablet, all is part of that one?
Yes, it's a full system. You tell us how many beds you want monitored, we do the installation, and we essentially provide 99% uptime. That's essentially our job. It's like your SaaS model, where a software company tells you that they will provide 99% uptime for a cloud-based software.
If you look at the last 20 years outcome over critical care as mapped through peer-reviewed prospective clinical data, I'm not looking at company data, I'm looking at clinical data, then irrespective of the various nuance differences which are employed across various places, there has really been no appreciable shift in critical care outcome. And that is something for clinicians to think about over the last 2 decades, right? Anyway, I can send you the link to, there are about 5 major meta-analysis looking at critical care outcomes across clinical spectrums. What happens is one set of disease gets replaced by the other, one set of severity gets replaced by the other. So at the end of the day, it depends what outcome parameters we are measuring. Are we measuring improvements in rate of clinical outcome? Are you measuring your cost effectivity in terms of HR contraction? Are you measuring your cost effectivity in the terms of number of times you've got to pay the clinician to come back to the hospital? So is it an outcome parametric analysis, clinical outcome parametric analysis, or is it a cost contraction parametric analysis? Remains a fundamental point in question.
Yeah.
Especially in critical care. I come from a hospital in Calcutta which had a mother of all disasters with a software of one. We have about 40, 45 critical care units. And we had a similar experience, sort of a mishap. I won't call that an experience, which really didn't, it basically led us up the garden path. So I think we need a little bit more clarity because I'm still not clear that what is the improvement. Cost is one matter, clinical outcome is yet another, right? And across some 1,700 or so, whatever, critical care situation you said, not having a code blue either means the nurses were sleeping or the health of India is terribly increasing, So there is only one of 2 possibilities. It is simply not statistically possible to have a clinical situation across 1,700 critical care beds where you are not recording a code blue. It's not possible.
So just to clarify, this wasn't ICU data. This is outside of the ICU in the
Right.
acute medicine ward. The data that is, our system does not sit in the ICU. The ICU is a very well-studied space, as you already mentioned. There is a lot of technology that's already there, and the improvements that you will see, even with newer technologies, disruptive technologies coming in, is still going to be very marginal. What we're looking at is more of a holistic approach. How do you increase patient monitoring outside? Like, let me give you a very stark example. Only about 20 to 30% of beds in India are continuously monitored. And by continuously monitored, I mean, you have several data points, not a nurse going around taking data every 4 hours or every 6 hours. Compare this to Western economies where 50 to 75% are actually continuously monitored. And why is that? Because they have a very specific use case. They need to reduce readmissions. They need to reduce cost of care. They need to optimize the cost per patient managed. Now that is where, yeah.
I think it has to be the same in India.
Absolutely.
Because if you look at the clinical scenario, I do not know of one medical condition for which you need to be in a hospital but not need to be monitored. I could be lying at home and watching television. It is a betrayal of clinical perception to say that I have a certain medical debility for which I can be in a hospital. Actually, at home, I actually have my wife or somebody of similar description around me.
Yeah.
Because being in a medical ward with a nursing ratio of 1:8 or 1:7 is a healthcare hazard, actually.
Exactly. So we're essentially trying to fix that.
I think unmonitored hospital beds is going to be a medical legal liability within a year. You cannot have unmonitored hospital beds anymore. It's an anathema, This is Lister's medicine.
Yeah.
This is not medicine of 2018.
Yeah. Thanks, Dr. Sarkar, for making my case for continuous monitoring in hospitals. Yeah.
It needs to be monitored, and you send it to all the doctors outside the ward,
That's right.
and they monitor, interfere when there is necessary.
Yeah.
But this new NABH, the protocol, it comes and looks into the documents and how much it has been written by your doctors,
Very
by
true.
consultants.
Absolutely.
So documentation, how can you maintain the documentation?
So this is automatically documented. So we automate not just picking up the vitals, we also record it continuously.
The doctor's interference, consultants.
The consultant
advice
has
and
all
that.
of the data on their phones.
Right.
The nurses are able to actually print digital copies of it to push it into the HIS so that documentation is maintained from a medical legal perspective. They don't have to input numbers anymore. It happens automatically. And we also integrate with hospital HISs. And our integration is far easier compared to your traditional monitors today. So what we've done essentially is change the paradigm of monitoring.
No, but his question is very important. Do you have the validity saying that this form of documentation, say I may have a lot of data on my phone,
Yeah.
but the mere fact that I have responded
Yeah.
to somebody's blood pressure diminishing or temperature increasing,
Yeah.
is that response
Yeah.
via the digital matrix,
Yeah.
is that valid? I think,
Yeah, that's
isn't
that's
it?
one
I
answer.
think that's a very critical question.
So,
Because
so
this is where we end up reduplicating, isn't it?
yeah. So
That you
there's
do this and that both.
so there's no duplication here. The clinician looks at it. He gives the nurse an instruction or the doctor an instruction.
I think you oversimplify it. I don't know of a system so far which doesn't reduplicate.
Well, I'm telling you, sir. I'm glad you don't know of a system that has that. I'm telling you that exists.
Okay, we'll
And I think that is the disruption.
Great.
I will. I'll close
Sure.
the conversation now and maybe take it up after our panel discussion if you have more questions on tech, use of tech, etc. But I'd like to